welcome you all to the bi-weekly Berman Institute seminar. It's a pleasure today to welcome Laura Senier, who, as I'm sure you've seen from the announcement, and the slide behind me is Assistant Professor of Sociology and Anthropology and Health Sciences at Northeastern University. I'm sure you've read her short biographical sketch, and so before we came over, I asked her what things I could learn about her that we wouldn't know from reading her short biographical sketch. So let me offer a few of those. She had public health training, which I didn't realize, so Laura did her an MPH at Boston University, PhDs in sociology from Brown University. And prior to her time at Northeastern, which began in 2013, she was at the University of Wisconsin at Madison. She has spent time, in addition to the things that she'll talk about today, working in environmental justice, and earlier in her academic career worked on soldiers and deployment health. I think that's how you described it, including the issues that arose during what became known as Gulf War syndrome. So thinking about exposure, health, readiness, mental health, public health. It's all really interesting areas, and I think it was very interesting today to hear from Professor Senier about public health genomics and state-based programs. So welcome to Hopkins, welcome to the Berman Institute. We're really pleased to have you here today. Per our usual approach, Laura will speak for about 45 minutes, and then we'll open it for questions and answers at that point. So please join me in welcoming Professor Senior.
Thank you so much. Can everyone hear me? Yeah. Okay, excellent. So the research that I'm going to be sharing with you today falls out of a K01 grant that I had from the National Human Genome Research Institute. It's looking specifically at what state public health agencies have been trying to do to integrate public health genomics work into their chronic disease prevention programming. I've also really been fortunate through this K grant to be able to support a number of crackerjack postdocs and undergraduate and graduate research assistants. My postdocs, Leandra Smolin, finished working with me last spring. She has just completed her first year on the tenure track at SUNY Potsdam. Lauren Nickel, one of my earlier postdocs, is now working, she's the Assistant Dean for Science, Business, Technology, and Mathematics at Community College of Rhode Island. Catherine Tan is going to be finishing up with me, starting a tenure track job at Southern Connecticut State University this fall. And then I've got a number of graduate and undergraduate research assistants. Rachel Lee and Mike Shields are both in sociology. Barrett Lindell was one of my undergraduate health sciences majors, and I just wrote a letter for her from med school. So really thrilled to be able to see the students that I've worked with succeeding on their paths in research and teaching as well. So I wanted to sort of set the stage a little bit by talking about public health genomics, because it's a term that many people are not familiar with. And in fact, when I was presenting on a panel a few years ago in Denver, the discussant started her comments in my paper by saying, when I first looked at the title for this paper, I thought that public health genomics had to be the biggest oxymoron I had ever heard. How could something as individualized as a person's genome ever be relevant to public health? Now let me tell you, when the discussant starts her comments about your paper that way, it's not always a good feeling. And we ended up in a good place, and she sort of ended up liking my work. But I just wanted to let you know that this. I understand that this feels a little bit strange to some people. I'm interested in it because I view this as an example of research translation, or dissemination and implementation. So if you live in the NIH world, you know that we are all under increased pressure to demonstrate that we can move discoveries from basic discovery to actual clinical applications and practice as quickly as possible. And as a sociologist, I'm interested in understanding what are the political, the economic, the social barriers in that process. I also, as Jeffrey said, I have this background in public health, however, so I'm interested not only in identifying those barriers, but understanding how can we make this research translation process more efficient and especially more equitable, so that the huge investments we make in biomedical research come to benefit everyone. So thinking about the Human Genome Project, as for example, we spent about $2.7 billion to map the genome. And when the genome map was completed in 2003, it was accompanied by very, very optimistic expectations that it would usher in this era of personalized medicine. It would increase healthcare efficiency and efficacy. There was, however, at the time, much less discussion about how we would leverage this huge public investment to reduce population burden of disease. And in my application to NIH in November of 2011, what I said was that state public health agencies are important nodes in our research translation network. There's a lot of attention to the link between research and industry, and a lot of expectation that pharmaceutical companies, for example, would leverage genetic discovery to make pharmacogenomics. But what I was telling them in 2011 was we really should also pay attention to our public health agencies and organizations and prepare them to find ways to maximize partnerships that will allow them to use genomics information to benefit the health of the public. So I view public health genomics sort of as a case study in this kind of research translation problem. Now, public health I know means a lot of different things to a lot of different people, so I just kind of want to get us all on the same page to start. This is a framework that was proposed by the Institute of Medicine back in the late 1980s. It's an effort to organize our understanding of all the diverse and disparate things that public health agencies do into 3 core areas. So there's an area of assessment. This has to do with surveillance, so understanding spread of disease, counting births and deaths, causes of death, so on and so forth. There's also this realm, this domain of assurance. So even where public health agencies aren't directly providing clinical services, they will help people refer people and connect people to care that they need. They are involved at the state level at licensing healthcare providers. They evaluate programs and enforce policies. And then on the policy development front, they mobilize community partnerships and inform and educate the public and providers about novel healthcare discoveries. So when you think about something like genomics, for example, so if we find that there is a genetic marker that increases your risk for disease, what public health agencies will be doing through their surveillance efforts is asking themselves, like, when, whether, and how does it make sense to actually start introducing this and integrating it into our surveillance efforts? When does it make sense? What do we need to do in order to help people find care based on new genetic information? How do we make sure that our workforce is up to date on scientific discoveries? And on the policy front, how do we educate providers and the public about the appropriate use of these genetic technologies? Now, in the United States, because we don't have one public health system, we have 50. It's run by the state level. It's always going to vary. It's going to look a little bit different. The story that I'm going to be telling you today in this research highlights 3 areas. One having to do with what they were doing to surveil and to monitor the emergence of health disparities, how they were helping to link people to find clinical genetic services, and how they were mobilizing community partnerships to help smooth some of those pathways. So what I'm especially interested in this project, and this is a paper that is now in press in Genetics and Medicine, was how state health agencies have understood health disparities and health inequalities as they have tried to bring genomics into their chronic disease prevention program. So I'm interested here in finding out about which types of inequalities they were most concerned about, and what kinds of programs they developed to sort of mitigate some of those barriers and the challenges that they encountered. So, as I said, we've been hearing all this rhetoric about the mapping of the human genome and high expectations about the precision medicine initiative. It's really only been within the last year or so that we have seen the term precision public health start to pop up in the literature. So precision public health as a complementary notion to personalized medicine, which is just the idea that we should be able to provide the right health intervention to the right population at the right time. So collecting data on genes, exposures, behavior, and finding ways to improve health in subpopulations who may be especially at risk. So any of you who have a background in public health and health promotion may be familiar with the work of a man named Geoffrey Rose. He was a British physician, and he wrote this very classic book called The Strategy of Preventive Medicine. And he proposed at that point that we should be thinking about 2 different kinds of public health promotion strategies. We could divide things in terms of whether they operate at the population level, So bringing a general population health message, health promotion messages to a very wide audience, or if we want to pursue a high-risk strategy, which is finding people who are especially at high risk of disease and offer individualized intervention. So to give you an example from cancer genetics, a population level campaign would involve a general campaign that would encourage women to start biennial mammography starting at age 50. A high-risk strategy would be identifying women who have a very, very strong family history of breast cancer, and then suggesting that they should seek genetic counseling and testing because there may be things that they could do to mitigate their risk. Early surveillance, prophylactic therapy, earlier and more intensive screening. So in the context of genetics then, and in the context of precision public health, people have been trying to understand, well, what does this mean for Jeffrey Rose's ideas? And people have been trying to propose that we need to update Jeffrey Rose's framework with this idea of stratified prevention. So these are some writers from Europe who are suggesting that the high-risk strategy should be further modified explicitly around looking at genetic risk. So that this will lead to an approach that will have advantages in efficiency, effectiveness, and minimizing harm. So I have a couple of critiques of this. First of all, I wonder if this is really substantially new and substantially different from Rose's original formulation of population or high risk. But I also think that this approach generally kind of presupposes the availability of interventions that would be relevant at each category of stratified risk. And then it also really kind of ignores questions about whether or not those interventions are equitably available to everyone who would need them. So what I have been watching then over the past several years is how 3 different state public health agencies have been wrestling with these discoveries about genetics and what it means for their cancer genetics and cancer screening programs. So any population level strategy that requires people to take some kind of action, meaning going to the doctor, changing some kind of behavior, utilizing screening, those kinds of interventions have the potential to exacerbate health inequalities or give rise to new ones if those those behaviors or screening interventions need resources that people don't have access to. And what state health agencies have been doing is they've been trying to find ways to devise their programs to draw from both of Rose's frameworks, the high-risk strategy as well as a population-level approach. So in order for something like the BRCA cancer example, in order to get that message about targeted screening and high-risk screening, you need to combine a population-level approach, educating everybody about the risks of cancer in order to find and locate and identify the small subset of women who might benefit from genetic counseling. What they have also had to do, however, is they've had to tailor their programs based on not only on finding those people who are biologically at increased risk, but understanding that some of those people who are biologically at increased risk also have other kinds of social vulnerabilities that affect their ability to get to access care. And importantly, these strategies vary across states, depending partly on the organizational capacity of the state health agency, but also on the demographics of their state's population. I'll make the briefest suggestion here about methods, and I'm happy to answer questions during Q&A if you have them. But this is a qualitative research study of 3 public health agencies, Michigan, Connecticut, and Utah. And I selected those 3 because I knew that they vary in the structure and in the content of their public health genetics program, either in how they were financed or what part of the agency they were structured in. The research that I'm going to share with you today is based on interviews that I did with people in those 3 state agencies, 85 people, some of whom worked for the state health agency, but also some of their stakeholders and partners in community agencies. What we found was that they ended up kind of developing 2 different sort of repertoires of action. There's something that we term the clinical management repertoire, and then the public health action repertoire. So the clinical management repertoire is very much based on the assumptions that people, the knowledge and the insight that people with certain genetic variants are biologically at increased risk, and the major job of public health institutions is to help connect those people to care. So it's very much about educating providers and the public about which patients might benefit from genetic counseling and testing, and in some cases educating people about who actually isn't necessarily a good fit for genetic counseling. So this is just pretty much understanding risk in straight up biological terms. If you carry the variant for risk of disease, you qualify for that high risk intervention, and we would help to try to find ways to connect you to care. The public health repertoire action, however, is an understanding that that programming needs to be tailored specifically to meet the needs of people who have social vulnerabilities that affect their access to services. So this understands risk as occurring at the intersection of that biological risk, but also the social characteristics that people have. So here's an example. Connecticut, for years, had been educating people about family health history, trying to help people understand that it's important to know what your relatives and your family members had as conditions, and to share that information with your healthcare provider because it might be useful in terms of diagnosis or treatment. They analyzed their data over time, and what they found was that the people who were most likely to be collecting that information and sharing it with their providers were largely white, highly educated, and upper income. And they realized that this was a big threat, a big problem for them in terms of health inequalities. So this is just an example of some of the tools that they had designed for family treatment. So they developed partnerships with 4 different community-based organizations to try to broaden the availability of that training on collecting family health history. So, this is an example of a family health history pedigree that, this is an example of one of the worksheets from that program. And they took it out to 4 different community-based organizations: a local health department, a federally qualified health center in Middletown, Connecticut, a Hispanic Health Council, which is a clinical services and advocacy organization, and then an organization that serves and helps refugees, Cambodian refugees in Connecticut. And what they found at the end of this intervention was that they were successful in educating people in these settings about the importance of family health history. And across all 4 of those settings, at the end of the intervention, about 75% said that people understood that family history is important and that they intended to try to share it with their physician. So, to take another example, the state of Michigan, one of the things that they did, they didn't necessarily, they have a state cancer registry, which doesn't necessarily have information on genetic indicators of risk. But what they did was they searched and they mapped cancer mortality rates by county for people who had, this shows breast cancer among women under age 50. So here, because they didn't have an actual genetic marker that they could look for, they used age as a proxy to try to understand and estimate where the distribution of people with cancer, early onset cancers, live in the state as a means of figuring out where they can identify and focus their programming. They did it for breast and ovarian cancer among women under age 50, for this is ovarian cancer, and then this is colorectal cancer. And what they found was that there were these pockets of the state, mainly in the Upper Peninsula, but also sort of here across the lakes from them, and that the patterns differed by different types of cancers. I've been continuing to follow them, the work that they're doing here. They're very, very worried about the thumb. They talk a lot about the thumb. What are we going to do about getting the services into the thumb? What they did in the Upper Peninsula, as an example, is they offered continuing medical education credits, an online CME module for primary care providers to help them understand not necessarily what suite of clinical services I should be offering to my patients, but just helping primary care providers understand what are the red flags. If I see a patient come in and they tell me that they have family history of the disease that follows this kind of a pattern, it tells the primary care provider that they should refer them to genetics. Utah did something very similar around this, public education and outreach. But what they found in Utah was that it was further complicated by population density. And in areas of the state in Utah that are especially rural, there are additional challenges there because the population is likely to be of very low socioeconomic status and not necessarily very well educated. So as one of the people that we interviewed said, in Utah, said, it's not just that people are geographically far away from services, but they're also financially far away from services. So some of the strategies that people used in order to tailor their programming to the needs of people in their state: they mobilized community partnerships, they educated providers, and then they embraced this strategy that we call, for lack of a better term, policy anticipation. So in Michigan, the Public Health Genomics program had a partnership with the Healthy Homes University. This was a program that's run by the Department of Housing and Urban Development as a means of trying to remediate homes where children live who have asthma. And what the genomics program people found was that people in the asthma program were collecting data on family history of asthma to try to understand, who in the family is affected by asthma, but they weren't necessarily doing it in a very systematic way. So the genomics team worked in partnership with the people from the asthma program to collect better data and more easily interpreted data about family history. And then the Healthy Homes people actually used that information to prioritize some families for special interventions. If they needed equipment, or if they needed mattress covers, if they needed, remediation of mold or dust mite infestations, people actually used that information on family health history, even in the absence of a specific genetic marker, to just understand how do we target and prioritize people for better services. In Utah, one of the things that they did, they had a very, very long-running program in partnership with the Utah schools to educate people there. And because of the presence of the Mormon Church in Utah, there's a very strong interest in family history and genealogy. And they were using these public education materials in the schools to teach children about family health history and how to collect information. One of the collaborators that we worked with described the Salt Lake City school district as minority majority. 65% are Hispanic Latino. The rest of it are qualified as other. There are schools where 102 different languages are spoken. So in taking this genetics education program to the schools, they needed to find ways to translate it not just linguistically, but also for cultural competency and sensitivity. One of the things that they did is they consulted with Pacific Islanders and Latinos to make sure that their materials were culturally sensitive. So in the original formulation, in the original curriculum, they talked about recognizing different kinds of inherited traits like earlobes that are connected, or tongue folding, if anybody, these are physical traits that are often run in families. And one of the things they were talking about in the original curriculum was hitchhiker's thumb. And the Pacific Islanders and the Latinos that they were working with said, this is not really kind of culturally sensitive. Can we find a different way to describe this? So they called it just thumb extension. So this was an example of how the state health agency, working with a community partner, made an effort to sort of tailor their materials so that they would better reach people who would be from different backgrounds. They also did a lot of work around provider education, and I've already explained a little bit about the CME programs that they were running for primary care providers in rural communities. Connecticut has also developed a really intensive program where they stationed and positioned a genetic counselor in a primary care practice to answer questions, to help primary care providers understand what are those red flags. And in some ways to sort of alleviate anxiety for the primary care providers. Like, we're not expecting you to become an expert in genetics overnight. We're just expecting you to be attuned to those red flags so that you know what you need to refer on. And then we came up with this barrier of what we describe as policy anticipation. So in all 3 states, the public health genomics program people that we talked with said that they expressed some frustration at some things that they were just not able to address, and especially with respect to the underlying determinants of social determinants of health, things like poverty or education or geographic distance. So one of the major things that they all mentioned was insurance coverage as a barrier in access to care, and this persisted even beyond passage of the Affordable Care Act. So with the passage of the Affordable Care Act, as you may know, not all states accepted Medicaid expansion. Michigan and Connecticut both did accept Medicaid expansion, although Utah never did. So this put we were doing interviews. We started interviews in the States in 2012, during the time when people were watching to see what would happen with the Affordable Care Act and trying to predict how it might affect access to health care generally, and especially how it might affect access to specialty healthcare services like genetic counseling and genetic testing. We also found, however, that in Michigan especially, they were not just waiting around to see what would happen with the Affordable Care Act. They were very proactive in doing some outreach to health insurance companies in Michigan. So they contacted health insurance companies, the medical directors in each of these health insurance companies. A lot of those medical directors in the health insurance companies don't have very much of a background in genetics. And what they did was they provided information about evidence-based screening recommendations for things like breast cancer, the BRCA1 and BRCA2 genes. So when they started this in 2008, they found that of the 24 health plans in Michigan, only 4 of them had health plans and health coverage that was consistent with the evidence-based recommendations to refer women with a family history of breast cancer for genetic counseling and possible testing for BRCA1. What they did with these health plans was they conducted outreach, and they actually provided sample language and templates that the medical directors could just insert into their certificates of coverage and policy documents to make sure that their coverage aligned with evidence-based recommendations, so that if patients approached for coverage, then they would be less likely to have lack of insurance coverage or insurance denial as a barrier. By 2013, they found that, of their original plan of pool of 24 health plans, they were now 25. 14 of them had brought their health plans into alignment with evidence-based practice recommendations. So this was something that was very effective, and it was something that the medical directors and the insurance companies said they really appreciated. So what the net effect of this was that about 7 million Michigan residents were able to access coverage, at least for BRCA screening, without insurance access as a barrier.
Can I just ask, is that just for the screening, or is it actually for the follow-up?
Just for the screening. Yeah. That is going to hold that thought, because there's a question coming up on another slide. So this just shows the variation across the country in Medicaid expansion. As I said, Michigan and Connecticut both accepted Medicaid expansion. Utah never did. And when we talked with people in Utah about the strategies that Michigan had tried to put in place, they said this just would never work for us. We would just never be able to do that in Utah. And without Medicaid expansion, they described trying to get coverage for clinical genetic services as a complete roller coaster ride. Even into the spring of 2017, I was there last year, and they said it is just incredibly catch as catch can. Whether or not a patient will be able to get insurance coverage, even for something that has been in place as long as it has, like testing for the BRCA gene. So this is kind of part and parcel of the whole difficulty and concern that they have about barriers and frustrations and challenges that, as public health agencies, they're just not able to address some of the core underlying social determinants of health. And the people that we interviewed were very cognizant of this, and they were often very frustrated by some of these barriers. Just understanding that remedying some of these barriers, like whether or not the state has taken Medicaid expansion, or the lack of good jobs, or the lack of education, are things that are just sort of beyond the scope of public health jurisdiction, and certainly their resources. This is an interview in Connecticut, and Connecticut is an interesting state because it is in a part of the country that is very, very densely populated, and as this person is saying in her quote, she's saying, we have some of the richest and wealthiest parts of the country, but we also have some of the poorest. And some of these disparities need to be addressed before we can even get to the underlying health issue. Even in a small, densely populated state like Connecticut, the genetic counselors and the genetic providers that we interviewed said they still have patients who have difficulty not just with insurance coverage, but also transportation to get to Hartford for a consultation with a geneticist. And if it's that bad in Connecticut, it is even worse in places like Utah and Michigan. And this also kind of caused some of them to even question the wisdom of some of these outreach and education activities. while it may be possible, theoretically, to translate educational materials into different languages, we still have this problem, as Gail says, where we're identifying people who need services, but may not necessarily be able to afford them. And this is from a person we talked with in Utah, and said, of course, now what do I do with this information? Now that I know all of this family history, what do I do with it? I saw that person thinking, okay, there's a step number 2, and people just jumped off a cliff, and people just, didn't get services. So the people in these programs that I've interviewed are very cognizant that they're trying to raise awareness, but that some of the people they're talking with are just sort of up against barriers that haven't yet been remediated and are kind of outside the scope of what a traditional state public health department can do. So I just want to wrap this up, and then we'll have some time for conclusion, for Q&A. Basically what we have found is that the state public health agencies that we were discussing, understood the limitations of the ROSE framework. They understood the critically important element, which is we need to educate the public generally about genetics if we're going to have a shot at identifying the very small number of people who might really benefit from genetic services. And they initially embraced what we sort of describe as this clinical management repertoire. They initially went into this thinking, well, our challenge is just to identify those people and then make sure that they have some kind of a pathway into care. They very quickly realized that there were these social barriers that people encounter that also needed to be addressed. And very importantly, they needed the main axes of vulnerability that they were concerned about, I've already alluded to: socioeconomic status, race and ethnicity, and the challenges of accessing genetic services in rural communities. And because these challenges varied from state to state, the specific strategies that the people used in different states were also going to have to vary. And it also meant that they needed to work with different kinds of partners in different states. So I also kind of think that this is a good opportunity for us to reflect a little bit about ROSE and the ROSE population and preventive medicine strategy framework. If any of you have read Rose's work, he never put these two ideas about health promotion out as mutually exclusive. You either do a population level or you do a high-risk approach. He always proposed them as things that would need to be integrated in order to really serve the needs of the full population. But I do think that what we are seeing is that we do need to find more granular ways to understand high risk, and that very often in the original framework, Rose thinks of the high-risk population strategy as people who are at high risk and just everybody else. And that what I think these findings show is that we really can't ignore the heterogeneity within populations. It reflects variations in communities that are substantively and historically very, very important. So I think that the Burton stratified prevention strategy is a step closer to precision public health, but unless we find some way to also build in these ideas about social vulnerabilities, this stratified approach can still end up ignoring health vulnerabilities and health inequalities. So I think I've just kind of suggested to you then that there are different things that state public health programs can do to analyze state surveillance data. They're trying to help connect patients to clinical services. They're finding ways, searching for ways to forge partnerships and collaborations with people who can provide services that they can't necessarily provide themselves. And that in all cases, like everybody that I talked with said, we understand that in public health we have this, certain kind of mission, and that there are things that are beyond our mission that we probably will not be able to tackle, certainly not in the current political climate. One of the questions that I often face when I talk with people from the state public health agencies is, well, what should we do? This is research that's based on a couple of, 3 different states, and I often hear from people in other states who are saying, well, what should we do in our state? And I think the biggest message and the most important take home that I'm trying to get people to understand is that the strategies are going to need to vary state to state. And in all cases, it's going to end up with starting with a really thorough analysis of your state surveillance data to understand not only what some of the population health burden may be for these genetic conditions, but also where are the social vulnerabilities in your population, racial, so SES, or rurality. So I'm happy to answer questions.
Thanks. So Pete has a microphone. Let's ask people to wait for the mic so that we can catch on tape. Alexis.
Thanks so much for your talk. I'm Alexis. I'm a postdoc here at the Berman Institute. And so you talked about different approaches in the different states, but I didn't hear you mention anything about different funding or budgets for public health genomics in the state agencies. I wondered if you could speak to that. And also a little bit more on the selection of the case studies, or not so much the selection, but if you could give us a bit more context about whether these states are kind of standouts in being very advanced in their public health. They're doing a ton, some states are doing nothing, and kind of what that landscape looks like.
Yes.
Thank you.
Two great questions. So with respect to the states, Michigan is the state that everybody wishes they had. They're the leader in genomics programming. They have a very large staff. They've had continuous funding from the Centers for Disease Control for I think 15 years now for different kinds of genomics initiatives, some of which were specifically around family health history, some of which were more specific around cancer genetics. Connecticut, however, had almost no funding, from the beginning. They had one staff FTE who was just kind of responsible for watching the landscape and bringing up novel discoveries that might be useful to public health at some point. And in spite of the fact that they had no dedicated funding, they really accomplished a lot on the public and provider education front. I like to say that they're a great example of what you can do just by vacuuming loose change out of the couch cushions. Utah was an interesting case because they had a CDC grant from 2003 to 2008 that wasn't renewed, and then the program kind of fell into a period of quiescence. And then in 2014, they got one of CDC's cancer genetics grant and were able to kind of revamp and start programs up again. At present, however, the CDC is only making funds available to a very small number of states. And they're treating these as kind of demonstration projects. So under the Affordable Care Act, they funded 5 states specifically around cancer genetics, partly for breast cancer, but also for hereditary colorectal cancer. And what they've been doing is making the materials that those states have generated available on the CDC's websites as templates and examples. I think it is an open question how far people are going to be, how far that approach is going to be able to go. There's also a clickable map, so if you go to the CDC's Office of Public Health Genomics website, it brings up a map of the United States, and you can click on your state and see a list of genetics providers and other prospective partners. So their CDC is trying to grease some of those skids. What was your other question? Funding and
Broadband choices.
Well, I think you addressed it because it was about how the states fit into the other states. Okay, thank you.
Hi there, I'm Holly Taylor. I'm on faculty at the Berman Institute in the School of Public Health. I had sort of 2 questions. You had a slide where you got feedback from folks about what I'll call the sort of pitfalls of outreach and education. And I'm wondering if you could say a little more about what they were thinking in terms of what those trade-offs were. I mean, I can imagine what some of them might be from an ethical perspective. I'm wondering how they phrase them. And second, whether you've seen any interest in these states or other states as these sort of less penetrant genes become available, and how on earth they might start to manage any of that.
Well, so your second question kind of starts to answer your first one, right? Which is, in recognition of the fact that there are these limitations on the capacity of public health systems to serve the public, the needs of the public, they've been fairly conservative about, trumpeting new advances. So at present, there are really only 3 conditions where there is enough evidence to suggest that screening for it might actually improve actual health outcomes. One of them is breast cancer, one of them is hereditary colorectal cancer, and then the third one is familial hypercholesterolemia, which is a particularly aggressive kind of high cholesterol that it sets on very, very early. So the American Academy of Pediatrics actually recommends checking cholesterol in kids as young as 8 or 10, I think. So there's a very small suite of conditions that the public health community has sort of said, okay, these are ones that we think are actionable. And this is what we can do right now, for lack of a better term, just to make sure that people understand who might benefit from these programs, and also who may not benefit from these programs. So in the BRCA landscape, when Angelina Jolie made her announcement in the New York Times about being tested for BRCA, one of the things that clinical geneticists across the country said they were inundated with requests from women who just wanted the test, because they had heard about this in the news. So part of the education challenge on the hereditary breast and ovarian cancer side has been in helping providers and the public understand who isn't a good candidate for that test.
Thank you for a really interesting talk. I also have two questions. So we have a large project here that is also sort of at the intersection between public health and genomics. And my first, it's partly a comment, partly a question, is to congratulate you on getting a K. One of our big questions and struggles here is the belief that NHGRI isn't particularly interested in public health. So I'd love to know how you frame things in your K to get them to be interested. I mean, in public health agencies, this divide between NIH and the CDC is something that we worry about a lot. So I'd just be curious to know from a process point of view whether you experienced that and how you addressed it. The more substantive question is just about newborn screening. You didn't mention anything about newborn screening. That's something that I actually think is very much a state health department function, and whether anybody mentioned anything about the relevance of all this to newborn screening policy.
Both great questions. So with respect to the first, and I also will say I'm meeting for lunch and then I have a conversation with the fellows afterwards. I am happy to share copies of my K. You can have anything you want. If you want pink sheets, if you want my revisions, I will, pay it forward. I had a lot of people who helped me with examples for my K grant, and I have a big intellectual obligation, karmic obligation to kind of help in that front. I think one of the things that helped was the hook on research translation, and I think the other thing that helped me with NHGRI was the hook on health inequalities. I think those are the two things. And then, what was your second question? Newborn screening. Oh yeah, right. So I was not funded on the first round for my NIHK, and one of the things that came back was a concern that it was a little bit too big. So on my second revision, I kind of tried to control the scope of the project by excluding newborn screening and say that I was only going to look at the non-newborn screening, those adult onset cancers and adult onset conditions. One of the things that I did quickly notice, however, is that a lot of state public health agencies have kind of siloed their genetics into the maternal and child health bureaus, so the chronic disease prevention program, people just don't have access to that kind of knowledge and expertise. So structurally, I think there are some things that public health agencies need to think about in terms of how do we help people within the agency collaborate a little bit more effectively. I wanted to say one more thing too about funding. You had a question about funding, right? About how states were funded. So CDC has a small number of grants that they have tried to provide, but some states have also done some other really creative things to try to get funding. So in both Michigan and Georgia, they convinced the State Department of Transportation to issue license plates with the pink ribbon. And all of the revenue from those special license plates gets funneled into a special program that helps to pay, and that will pay not just for the genetic counseling and screening, but will also pay for breast MRIs or other kinds of services, clinical services the women may need as follow-up. So states are kind of trying to figure out, like, how are we going to work around these things?
Anybody in the back? My eyes are not that good. I want to make sure we don't.
One thing I was wondering about to kind of zoom out to how precision public health is being defined. One thing that came out for me was I was thinking about how in precision medicine it still tends to be a very sort of technology-driven, like the innovation is happening because of the technology and not from the translation as being considered as part of that innovation enterprise, or just what's here. And I was wondering, is a similar thing happening in precision public health, or are these other forms of precision and individualization which include cultural competency? And is that being elevated as part of precision, or is it just, well, that's just how you implement?
Good question. Is the technology tail wagging the dog here? And I don't think that that's the case. Moeen Khoury, who is at the CDC in the Office of Public Health Genomics, he wrote that article about precision public health that I showed from Genetics and Medicine. And that article, he deals not just with the chronic disease and the adult onset cancers, but also infectious disease. The infectious disease landscape, I think, is an area where, because of sequencing and because sequencing has the potential to help with outbreak investigations, the technology is perhaps a little more ascendant in that kind of realm. What I have seen so far, however, in the chronic disease, adult onset cancer realm is precision public health is more about kind of elevating the tools we already have, like family health history, which has been around for decades. Like the state cancer, every state has a state cancer database. None of them have markers or fields in them for who's got BRCA, but they all have a field for, age of onset. So you can use that as a proxy to determine or to estimate the public health burden of early onset cancers in your population. So I think it's kind of a mix, and it probably varies depending on the particular area in public health.